Started.
Perfect. So I'm Jacob. I'm one of the F1s. I'm currently at Withenshaw, and I think there's a bit of a range of you who are in the talk, whether it's like third and fifth years as well. But we're just going to try and cover some of the cardiology topics which will come up often in finals, but also look at it as a perspective of what you might need to know when you're an F1. Oh, and sorry, yeah, my email is there at the bottom as well. So if anyone has any questions which they want to ask me after it, or just want to get in touch with any other questions, like feel free to email me. I'll put it up back at the end as well. And it will work better if people like interact. If you either want to speak out some of the answers or just type it in the chat box. I've got the chat box up as well. So we're going to cover 4 cases which are on your core condition list. And we're just going to try and go over them relatively briefly so that we can cover them within the time limit. And then there's a couple of ECGs as well, so we can talk through them as well. So we'll kick off with the first case. So in the first one, you've got to imagine this might be you next year. If you're one of the 5th years, you're one of the F1s on call for ward cover. And you get called to come and review an 87-year-old patient who is using a 3. So you ask the nurse what they're actually scoring for, and their heart rate's 123, blood pressure's 125 over 87, oxygen's a bit low at 93%, and the respiratory rate's 18. And you don't know anything about this patient, so you ask the nurse why are they here, and they say that they're currently being treated for urosepsis, and they've had a dose of IV gentamicin. So does anyone want to say what approach they're going to take? How are you going to start off tackling this case?
I can start just to, if anyone's so everyone's able to chat. So first of all, I mean they're scoring first of all, so that immediately makes me think they may be an acute patient. I can see that their heart rate's raised. The oxygen saturations are a little bit low, but not outrageous. And they're being treated for urosepsis. So I'd want to do an AT approach to start with and kind of go from there.
Yeah, perfect. So anyone who's a bit acutely unwell, if you're getting called to go and see them on call, doing your A2E always makes sense. And it gives you a structure so that you know how to actually assess the patient and see what's going on. So you go and do your A2E, and airway is patent. DB, the chest is clear, respiratory rate's 18. You put the oxygen probe on yourself and it's actually 94%. You sit them up a little bit and it goes up even further. So you're happy with A and B. Then moving on to C. So cap refill time is 2 seconds. The pulse is strong, but you think it feels irregularly irregular. Mucous membranes look moist, calves are soft and non-tender, no chest pain, and their blood pressure is stable. Moving on to D, GCS is 15, and E, have a quick feel of their abdomen. It is soft, but they're tender suprapubically. So what investigations would you want next? Yeah, and anyone just write any in the chat or anything? I've got the chat up, so yeah, if you're happy to just type it in there.
So sometimes there's a bit of a delay as people are typing or so someone's mentioning ECG.
Perfect, yeah. So an ECG is one of the ones you want, but when you're structuring your tests and stuff, which you always want to do, it's always good to think about like bedside, bloods, imaging, and others. So you've kind of done some of your bedside ones already, getting your obs, and then the ECG is your other obvious bedside one which you want to get. You'd also want to get some blood tests, which we'll move on to, and then you could think about imaging, but nothing jumping out immediately at this point. So you do the bloods, and some of the bloods which are important to do if someone's going quite tachycardic, you obviously want to do their full blood count. If they're quite anemic, that could be affecting it. You want to do their U's and E's as well to look for any electrolyte abnormalities, and it's always a good idea just to check their thyroid function as well. And with this patient, you can see he's a bit anemic, which you might expect someone who's acutely unwell, and his white cells are particularly up. Biochemistry-wise, his sodium looks fine, potassium's a little bit low, but thyroid function's normal. So we move on to the ECG. And I'll just kind of talk us through this one. We've got one later on, which someone can attempt to do if they want. So I'm sure you've already been taught about kind of your approach to ECGs, but particularly when you're on call, if you get handed one, always do actually make sure you check the patient name at the top, because I have had the wrong one handed to me before. So first of all, you'd start off looking at the rate, and you can see that the rate in this one is looking particularly fast. If you look at the rhythm strip on the bottom, you'd see that the rate of this one's probably about 150, 160. And then you'd look at the rhythm. So you'd already felt their pulse and it felt irregular. And looking at the rhythm of this one again, you can see it's irregular. Can't see any signs of any axis deviation, and you can't see any P waves. So this means it's not sinus rhythm. Looking at the QRS complexes, they look narrow. Can't see any signs of any ST segment deviation massively. And there's no massive abnormalities in the T waves. So given the ECG and given the presentation of the patient, does anyone want to suggest what's going on and why this patient's heart rate is up? Just type it in the chat box. Yeah, so it's likely this patient has gone into AF and fast AF. And yeah, perfect. Fast AF, possibly secondary to infection. So a good thing which would be to know, I know some people have said, so I've got a message, someone saying that it's new AF. So when you look at an ECG, you always want to get an old one to compare it to as well. So was this gentleman always known AF, or is this a new episode of AF? And in this case, the patient didn't have AF previously, so this was a new case of AF, and his heart rate's running fast. So we often call that fast AF, but more accurately in cardiology, they like to call it AF with a fast ventricular response. And we got taught this acronym in Leeds, which is where I went to medical school, of like some of the causes of fast AF, which I always try and run through because it comes up quite commonly. And it's pirates. So P for PE, I for ischemia. In both of these, he doesn't have any chest pain, didn't have any signs that it might be either of those two. R for respiratory disease, again, didn't seem to be likely in this patient. A for atrial enlargement or myxoma, which isn't something I tend to get too involved in. But T for thyroid disease, thyroid function was normal. E for ethanol, not sure whether he's drunk anything, but unlikely because he's in hospital. And then S for sepsis. So it's likely that in our patient, he's gone into fast AF because of his sepsis.
Sorry to interrupt, Jacob. Do you mind just going back to the ECG briefly? Oh, yeah. So, I agree with your assessment, absolutely. Though there is one other thing. There are some ST changes actually on the ECG, and sometimes they're a bit difficult to pick up when the patient's in fast AF. So if you look at AVL, you can see that there's quite a dramatic ST depression.
Yeah,
if that's clear. And then even in lead 3 and AVF, there is some ST elevation, and V3 to V5 and a little bit to V6 as well, there is ST depression. So, it's important to take a history and whether the patient's having chest pain, but these could just be ischemic rate-related changes. So yeah.
Yeah, definitely. And it is always important to then look at your old ones as well to see if they're known and get the history. So this guy wasn't having any pain, so something which we weren't too worried about. So with your management of fast AF, you always look at your tachyarrhythmia algorithms. And in those ones, you start off at the very top. So we're starting off to see whether there's any features of shock or syncope, which our gentleman hasn't had, and then myocardial ischemia or heart failure. So with your tachyarrhythmias and your bradyarrhythmias, these are always the starting point. Check if there's any adverse features. And in our case, our gentleman didn't. If they did, that's when you'd be needing to get senior help straight away. But we're going to move on back down the pathway. So looking at that QRS complex, so we looked at that complex and it said that it was narrow. So following it down even further, and was it regular or was it irregular? And we said that the rhythm of it was irregular. So that leads us down to this bottom bit of the pathway again, which tells us that diagnosis helpfully as well, which you've already established. So probable AF, and it shows that rate control is best with a beta blocker or diltiazem. And if they're in heart failure, that's when you can consider digoxin or amiodarone. We'll go into the management more in a little bit. And then this is the full algorithm. So sorry, it's a bit blurry. I couldn't get it over from the PDF better than that. I'm not going to talk into the full algorithm because I know you'll have like an ALS session as well, apparently. But learning the tachyarrhythmia and the bradyarrhythmia pathways are really, really important. And they're some of the most important things that you can always just commit to your memory. So we're just focusing on the bit which we just uncovered, but it's an important factor to look back on as well. So just a little bit about what atrial fibrillation is in general. So I'm sure you all know it's just disorganized electrical activity in the atrium. So instead of your atria pumping nice and coordinatedly, they just kind of flutter around. You also get the fast conduction through the AV node, which can cause your heart rate to go fast. And there's kind of many causes of it, which are easiest to think of kind of in cardiac and non-cardiac causes. So your cardiac causes of it, again, can be ischemic heart disease and valvular heart disease. And your non-cardiac causes can be mainly things like hypertension and hypothyroidism. It's always important to think of whether there's any pulmonary vein triggers as well. So these can be sites which are in the pulmonary veins, which can be sending off other electrical impulses, which can cause atrial fibrillation, which is called ectopy. And looking at kind of the clinical features of AF, so a lot of the time patients are completely asymptomatic and they might not know they're in AF. Sometimes they can have palpitations or shortness of breath. And when you have a little feel of their pulse, it's going to be irregularly irregular. And the investigations, which we already talked about, so you'd get your ECG, you get your bloods, and like I mentioned before, always important to make sure you check kind of your calcium, magnesium, and your other electrolytes in any people with any arrhythmia, just to make sure they're all normal. You'd want to get an echo, which would check for any structural heart disease and looking at that left atrium size. And you could get a chest x-ray to see if there's any signs of heart failure at all, which are happening because of the AF. And then moving on to the management, we've got kind of this three-pronged approach, which comes up more on the next screen. So rate control is kind of the first step, which we think, and you've got two main options, so beta blockers and rate-limiting calcium channel blockers. With your beta blockers, people often get a bit tetchy if their blood pressure's low and you don't want to use them. So in our patient, he was hemodynamically stable, so it would be fine to have used a beta blocker, trialing something like all-loprazole on him first. But if you did have any concerns, then that's when you could use things such as digoxin. One kind of thing to note as well, which I often have when I get a call to patients on call, is sometimes they may be going fast in AF, and then you'll have a little look, and they might not have even had their kind of evening or their normal daytime beta blocker. So always have a look to see if patients have had what their normal rate control is, if they're known AF, and then you can go from there. Rhythm control is something which, as an F1, you're less likely going to be involved in, but something which you do need to consider, particularly if patients are younger. If they're highly symptomatic, if they've got features of heart failure, or if it's been really recent onset. And that's when you've got the two options of either electrical or pharmacological cardioversion. For that level of management of it, that's when you're going to be speaking to your cardiology regs and getting them involved if you think someone might be suitable for rhythm control. And then you've also got those options of things such as catheter ablation, which is where they can go in and ablate those sites where they're getting the ectopic origins of depolarization. And then anticoagulation is one of the things which is also really, really important to think about. And that's when you have a little look at your CHA2DS2-VASc and your HAS-BLED scores. So if you get up MD Calc, you can go through those scores for both of them. And it's really useful to do on all the patients who have got AF. So if someone has a CHA2DS2-VASc of 1 or more in a man or 2 or more with a female, that's when you would start to think about anticoagulation. Obviously, you have to factor in your HAS-BLED bleeding risk as well. And often with your anticoagulation, you don't have to decide there and then if you're going to anticoagulate them, but it's something important to bear in mind for the long-term management of these people with AF. So that's kind of like a quick cover of AF, and we're just going to move on to our second case. So you've gone into F2, you've got your placement in GP, and James is a 63-year-old Afro-Caribbean man who's come in because he's concerned about his blood pressure. He said that some members of his family have had high blood pressure and he wants to get it checked. So you check his blood pressure in clinic and it's 152/92, but he's completely asymptomatic, not complaining of anything. What do you do next with this blood pressure? Anyone want to type in the chat box what your next? Yeah, so one of the things you want to do is you need to confirm the diagnosis. And that's because a lot of people get high blood pressure when they go into the clinic. So what you want to do is you can either do ambulatory or you can do home blood pressure monitoring. So if you have to explain them, like ambulatory, they often come into the practice in the morning. The nurse will put the blood pressure cuff on them, and it will just inflate automatically throughout the day. I think they need about 14 readings to make sure that you get an accurate diagnosis of it. Or you can give them a blood pressure machine to go home with, and you have to tell them to record it 2 times a day and take 2 readings each time. So you do 2 readings in the morning and 2 readings in the evening. Once you go home, he goes home, does the blood pressure monitoring, and his confirmed home blood pressure is 155 over 98. So comes back and you'll need to think about what you're going to do with that. So the way you decide what you do with your blood pressure is looking at what classification of hypertension it is. And we classify it to these stages, as you can see on the screen. For stage 1, which is when it's over 140 and 90 in clinic, that's when you often just think about lifestyle management. So that's offering advice on diet, alcohol, smoking, and exercise. There are some cases in stage 1 where you are going to want to start treating their blood pressure. And that can be things such as if they've maybe got underlying health problems like diabetes, if they've got CKD, or if they've got a QS score of over 20%, that's when you'd also want to treat these patients in stage 1. But often it's good to try and use lifestyle management in those ones. Whereas once you're in stage 2 and above, that's when you definitely need to put in a bit of pharmacological management. And I know this is something which everyone kind of always gets taught, but it's always useful to just go over it as well. So it's really important with your algorithm. So if you're under 55, you start off with A, which is an ACE inhibitor. Whereas if you're over 55 or Afro-Caribbean, then you'd start with a calcium channel blocker. And then you progress through the algorithm. So if your blood pressure is not adequately controlled on one of them, you can try them both together. And then you can also add in a thiazide-like diuretic if the 2 of them together doesn't work. There are a couple of kind of like differences from this algorithm which don't come up, which are useful to notice as well. So one of them is that if you've got a diabetic patient, ACE inhibitors are first line for managing their blood pressure, even if they are over 55. So that's an important variant to note. And one of the other important variants is, well, I'll just see if anyone knows. So if you tried a calcium channel blocker in our patient James, because he was 63 and Afro-Caribbean, and he didn't tolerate it because he developed some leg swelling, does anybody know what the second line treatment would be for him? I'll give it a second just to see if anyone wants to suggest. So you've tried amlodipine and it's not worked. What are you going to offer him? So I've had a couple of messages saying start ACE inhibitor. So this is again where it does vary a little bit. So if a calcium channel blocker isn't tolerated by a patient when you try it first line, then you actually go for a thiazide-like diuretic second. And that'll be something such as indapamide. And that's recommended in your NICE guidance. So that is one of kind of the 2 variants from this normal algorithm. So the first one is diabetics give an ACE inhibitor regardless of age. And the second variant from the algorithm is that if a calcium channel blocker isn't tolerated, then that means you'd go for a thiazide-like diuretic as your second choice.
I've got a question, Jacob.
Yeah.
If that's okay. And this question is for the audience and also for you. So if you go back to that algorithm, so if you've got a patient who has hypertension and you start them on a medication and you recheck the blood pressure to see what the response, and it remains elevated, do you increase the dose of the single agent that you've got, or do you add in a second agent? And similarly, so what's better? Do you increase the dose or do you add another medication?
So first of all, I always think you check them actually taking the medication if it's not working. Often with like the blood pressure ones, they can sometimes be like, oh, my blood pressure is fine, so they stop taking it. And then you titrate up your dose before you add in a second medication. So you often start off with things like ACE inhibitors and ramipril. You'd start off with about 2.5 milligrams, and then you can go up to 10 milligrams. So it's better, as far as I'm aware, to have people under control on one drug before you start adding in the second one and moving up the algorithm.
Okay, so actually that's a very common approach, and actually I would say that's not the right thing to do.
Okay.
The reason for that is that you're more likely to get more side effects the higher the dose, number one. And number two, in hypertension, there are multiple different mechanisms that go out of that result in hypertension. So actually having a lower dose of different agents that tackle different mechanisms, actually you find better blood pressure control in that situation, and there's less likelihood of side effects. So I personally, in my approach, is that actually, if a patient's on 5 milligrams of amlodipine, I would keep them on that 5 milligrams, and I'd encourage them to have an additional blood pressure tablet. And I actually tell my patients what I've just said, and most of the time, actually, they prefer to be on multiple medications at a lower dose with less side effects.
Okay. Is there a point where, like, what kind of level do you just add it in straight away, even if you're on the lowest dose, like another one, or?
Yeah, so for example, the classic one is amlodipine 5. So if you go from amlodipine 5 to amlodipine 10, the additional blood pressure lowering effect is very minimal, but the risk of getting side effects and like leg swellings, for example, is a lot higher at the higher dose. So I actually would go with ACE inhibitor to 2.5 milligrams, as well as the amlodipine 5, for example. And I probably would increase slightly the amlodipine, as long as the patient didn't have any side effects from it. Yeah, the other interesting thing about hypertension as well is that a lot of the time patients may have other indications for these medications. So if they've got heart failure, or if they've got angina or ischemic heart disease, or arrhythmias like atrial fibrillation, then you should choose the agent that deals with the other problem. So the hypertension is a secondary thing. So if you've got a patient who's got AF with rapid ventricular rate, rather than put them on amlodipine first line, put them on a beta blocker and titrate that as much as possible.
Perfect. I think so. A couple of people in the chat have just asked, is that nice guidance or your experience? I know it's definitely a nice guidance what you just said about if they've got underlying conditions, start off with a antihypertensive which targets that. Do you know, with the nice guidance, do NICE recommend increasing the dose and then adding another one in, or do they recommend?
To be honest with you, I'm not sure what I'll have to look that up in terms of the NICE guidelines about up titration. I don't think it's specified, but I have to look at that in more detail. I think it just mentions this approach. I don't think it mentions about exactly the up titration.
Perfect. Yeah, sorry guys, that'll just be something just to check on the actual NICE guidance then afterwards, and we can always have a little look and let you know. But we will move on to the next case, if that's all right. So case 3 is again another gentleman. So Harry's a 73-year-old guy who's coming to GP, and he's complaining of a couple of symptoms. So he says he gets chest pain when he starts walking, and then followed by a syncope, which spontaneously resolves. And then on examination, you have a little listen and you can hear a harsh ejection systolic murmur, and you feel that he's got a slow rising pulse. So given in mind with those kind of like hallmark presentations, what investigations would you want in this patient? Yeah, so everyone who's messaging me seems to be agreeing as well, thinking like this characteristic aortic stenosis, you're going to want to get an echo. And also, don't forget that you want to get an ECG and you want to get a chest X-ray. So with an ECG, you want to look out to see whether there's any kind of conduction abnormalities or see whether there's any changes which are associated with aortic stenosis. And we'll go on to have a little look at the ECG in a second. On the chest X-ray, you might be able to see kind of a calcified valve, which is one of the main causes of aortic stenosis. And you can often see some other features of it as well. So you might see an enlarged heart, and you might also see the aorta after the calcification can sometimes be dilated. That's called the post-stenotic dilatation. And then, like everyone's rightly said, an echo. So that's going to be diagnostic of the aortic stenosis. So this is the ECG for this patient. Does anybody feel brave or want to kind of talk through their interpretation of it at all? Anyone want to volunteer themselves for it? Okay, well, I'll give us a go to talk it through then. So again, check your patient details, and then you'd have a little look at the rate. So looking at the rate of this one, it's about 60 beats per minute. So it's regular, and looking at the rhythm, again, generally regular rhythm's looking fine. You can see P waves before each one of the QRS complexes. So it's sinus. And then also just having a little look at the axes. So looking at leads 1 and lead 3, you can see they're leading away from each other. So we've got a bit of left axis deviation. PR interval looks normal. QRS complex, it's on the borderline, but it's 3 small squares. So it's about 0.12 seconds. And then have a little look at your ST segment. So again, looking for any changes. In these leads here, it does look like there's kind of a high takeoff, and this is where it's important to have a little look at where your old ECGs are. But the main feature which we want to focus on is looking at this kind of large S wave in V1, and then you've got your large R waves in V6. And these are the signs of hypertrophy, or left ventricular hypertrophy specifically, which is a key feature of aortic stenosis. And some of your criteria for making sure to see if it is hypertrophy, if you take the S wave in V1 and add it to the R wave, the largest R wave out of V5 and V6, if it's over 35 millimeters, then that's diagnostic of your left ventricular hypertrophy. So just having a quick summary of aortic stenosis as well, and what kind of the causes of it are. So one of the main causes, and the most common one, is degenerative, plus or minus calcification. We've got some of these other rarer causes underneath it. The main pathology which is going on is because you're getting this thickened valve as you get your obstruction to your left ventricular when it's kind of trying to pump it out. So you get your left ventricular hypertrophy. Because of that hypertrophy, you get increased myocardial oxygen demand, which means when they're exerting themselves, you get an ischemia because you're not been able to empty the blood out of that heart as quickly. And because of that ischemia, it can cause that angina pain, which we described, and then you can get the arrhythmias. And again, with aortic stenosis, generally they're asymptomatic until they're quite badly stenosed. So it's until that aortic orifice is about 1/3 of the size. But you get that classic triad of symptoms, which always comes up kind of in exam questions, where you get angina, exertional syncope, and you can get dyspnea on exertion. Sorry, I've skipped ahead a little bit. And some of the classic signs as well. So you can get an ejection systolic murmur. So it's loudest in your aortic area and it radiates up into your carotids. And it can sometimes be preceded by an ejection click. So that is when you get a calcified valve which kind of flips open, and you can hear kind of a clicking noise of it. You also get a narrow pulse pressure, and that's because as your heart kind of contracts and pushes the blood out, it's pushing it out more slowly. So you're not going to reach as high a systolic pressure. So if you've got quite a narrow difference between your systolic and diastolic, that's what you call a narrow pulse pressure. You can sometimes get a thrusting apex beat as well, which is because you get that left ventricular hypertrophy, which you can feel, and that's when you feel for your heaves and kind of your palpable murmurs. And again, your investigations, which we talked about, so your chest X-ray, your ECG, and your echo. And with your management of it, so if a patient is asymptomatic, you can often just observe it and have a little watch to see how they're doing. You can consider interventions if their valvular gradient, so if the pressure difference is over 40, or they're starting to develop features of LVST. If a patient's symptomatic, then you want to replace the valve. And you've got your 2 main options, which are kind of surgical, and then a TAVI, which is where it's less invasive. In general, if you're a low-risk surgical candidate, we go for a surgical AVR, whereas if you're a high risk, we go for the less invasive TAVI. But again, that's a decision which cardiology will make. So we'll just move on to kind of our last case now, because I know we're coming towards the 45-minute mark, which was told how long to keep it to. And this one's kind of a bit of a different approach, where it'll just highlight some other things which we've not covered yet.